Hello, everybody. My name is Florin-Eugen Constantinescu. It's a great honor and privilege to present along such an important group of speakers, amazing clinicians, mentors, and friends. I first would like to thank my father for all his continuous effort to push things forward with the Stomatoedu Journal, my late mother for her love and effort to raise me to be a good man, and to both of my parents who helped me grow to become passionate dentists. And nevertheless, my wife for letting me dream and act as everything is possible. I'm grateful to bring in front of you a bit of my experience. This is a place where I spend most of the hours of a working day. We are fortunate to use many amazing technologies to help us provide an innovative treatments. I have always enjoyed and learned from good quotes. My focus is mainly on peri-implant prosthetic therapy, starting from a principle of complex digital diagnosis, carefully evaluating temporomandibular disorders with the aim of providing patients with an individualized oral rehabilitation. I strongly believe in technology and I use it on a daily basis with strong protocols to carefully understand each patient need of treatment. Neuromuscular dentistry has been present in my life since my early beginnings, and with this approach, I diagnose and treat most of my patients. This case I will go through very fast. The part of it was published as a case report last year. It was a big challenge. The patient came in with severe deep bite, chronic facial pain, painkillers taken without effect with bad endo, compromised prosthetic work, bad dentistry overall. We used our protocol and measured and taken all the information we could obtain from our patient, and then we sent everything to the lab and went through the prosthetic treatment plan, which in which we increased the video by more than 7 millimeters at the first touch. Of course, everything was measured either through kinesiography, electromyography. The patient did not use painkillers anymore, started to chew correctly. And we changed a little bit of her situation. She's also very grateful of this change, but it's not finished. Now, last year, we started the new normality, as I called it, and we started communicating 4D our patient status, fully digital, and all the information that we got from the patient, like face scans, CBCTs, also dynamic, functional dynamic registrations. We provide the lab with the patient's dynamics. We actually register the patient even when they are trying to eat. I remember a patient asked me for meatballs when I asked him what he would prefer to eat during a registration. We give this information to the lab, and now the lab is able to measure, design each tooth, form, and size in an individualized manner, as you can see in this video, in a dynamic approach, not in a static approach, but in a dynamic approach, a whole new world of possibilities. At fit, a tough case becomes an easy case to mount. As you can see, the patient finds the occlusion easily and receive his or her teeth without spending time with the occlusal adjustments. We put everybody to chew instantly, and a difficult case, as I said before, is easily approached when you have to place the new work inside a patient's mouth. Although
Tap, tap.
we still check the occlusion the patient receive, the teeth, and as I said, can easily chew instantly. We do the occlusal checks to see everything is fine. But the wonderful thing is that what was planned works and is delivered in a precise and predictable manner. Returning to my topic for today, through bone regeneration, I try to apply all my concepts by abiding the minimal invasive philosophy. Although I have prepared some cases where I used innovative biomaterials for bone augmentation, I won't present them all, although I have prepared them. I will limit myself to this 25 minutes. So, cutting it short, I always asked myself, did our teachers give us all in dental school, give us enough? It's enough for what we learn in school. There is a lot of, in my opinion, a lot to learn even after the school. I think we live wonderful times regarding medical and technological progress. We still have a lot to learn and to see. So we often have this question. The companies will provide a wide variety of products that come along with different techniques, but are all of them will turn successful in our hands. One can try and have some failures also, but of course, the more failures you have when you begin using a technique or product, the greater the chance for you to abandon that road along the way. We should never forget and always have this in mind when performing surgeries. We have to respect biology and think of everything that's going on. We have to understand how our physiology works and respect our liquid gold and how the blood vessels are forming, especially when we are doing surgery. Although I have used different type of biomaterials, the following attracted me because, in my opinion, was by far the easiest in use, and as this old principle was available, I like to keep it as simple as I can when performing a surgery. There are a lot of synthetic biomaterials on the market. I will speak of synthetic biomaterials and especially of beta TCP. There are a lot of available on the market, as we can see in this article by Gia and et al. But the main thing that attracted me and raised my interest was that I found that this biomaterial needed no membrane, was osteoinductive and improved the angiogenesis, and it was something that was very, very nice to see a combination of calcium sulfate and beta calcium phosphate that can afford to get a good result with our surgeries. Of course, our ultimate goals always are to think more and do less surgery, do less trauma for the patient, of course, inflict less pain, to have, of course, less complication or less morbidity. So less is more. I find it always to be true. Speaking of my contents, I will speak about guided surgery, internal sinus lift, immediate loading, some bony defects and split crest. When we do guided surgery, we have to plan before we act. So we always do the wax up. This is the classical wax up, and with that we superimpose it with a CBCT. We then plan the surgical guide, and according to the surgical guide, we do our surgery. Although I like to use guided surgery at every case if possible. Even when I have the surgical guide, I like to raise the flap to have a clear view of what I'm facing. An old saying was, seeing is believing. For instance, in this case, I placed the implants with the molars with the internal sinus lift, delicate approach, but the result was predictable just because I followed the special protocol, and step by step I show here how everything was reconstructed, the suture, and then after 3 months of time later at re-entry we found a thicker soft tissue and integrated implants. An important fact, after at the surgical re-entry, having a surgical guide used during the initial surgery, we can also do the re-entry in a minimal invasive way. So as the thicker the soft tissue we get, the better. This fact is also what the literature suggests. Professor Linkevicius states this in his article. Of course, tissue is the issue. The more keratinized tissue we have, the best is for our bone to protect our implants, and the results are also predictable if you use certain type of approach. Going to more implants with immediate loading. This patient came in with a compromised case, a heavy smoker with perio-affected teeth, bad oral hygiene, as you can see. Everything was done according to our protocol. We measured and we planned, and then we performed our surgery. We did the bone reconstruction necessary, also did some tissue management. But what is important, that the end result was a very nice one regarding tissue and also bone. And nevertheless, the patient did not change his oral hygiene habits. The tissues are looking wonderfully. And here we see the result with the provisional at 6 months post-op X-ray and 1 year photo, and also some 5 years after the final work was placed inside. Going through another case with all or nothing, as I joked about it, a tough case with broken implants, compromised teeth with perio problems, and a lot of things to deal with. What we can notice here in the CBCT, for instance, at the canine area, the huge defect that we restored, as you will see later on. We try to avoid by using the technology and surgical guides to avoid this broken implant, because it was too much hassle to remove it, also for us, but also for the patient. And although we plan a surgical guide, and for instance, the patient, for this case, we did 2 guides to firstly place the posterior implants, then extractors, oral teeth, and place the anterior ones. Unfortunately, we had some inferior measurements on the ISQ that did not allow us to do the immediate loading, so we had to delay our loading for this case, but we obtained in the end good tissues, and you can see here on the right hand side how the canine area, which was only a huge defect, is looking with the implant placed. The inferior was better, meaning that we had good readings, and we could have placed, due to the good ISQ, the implants and to load them. Of course, big defects reconstructed with the beta TCP and calcium sulfate biomaterial tissue management and sutures. I won't go with all of this, but what is more interesting at the end is how the tissue responds, how the tissue is responding when we are doing something that should be easy for the body. So I always prefer the body to do the work, to do the healing, and to do things as simple as possible. Another case of internal sinus lift, a young guy with no bone after a bad extraction. We see here in this CBCT we got 2.8 in the place of in the central place of the upper left molar, but with the crestal approach we did the internal sinus and push everything inside the biomaterial, placed our implants, and then waited for some months, and then when the patient came back to do the re-entry, got good bone. We respected the one abutment concept. We took also the impression, and what is good in the end is how the bone is transforming. As you can see here, the level of the maxillary sinus floor, how everything changed and improved by doing correct surgery. Another case, a tough case, a split crest case. A young smoker came in, and you can see the before and after pictures and radiographs that got rehabilitation with an implant supporting crowns. Going directly to the surgery, the posterior mandible split crest is a tough thing to do, but we managed to place the implants. The gap was filled with the biomaterial. We then sutured and kept our fingers crossed. The CBCT at 6 months showed us good healing and a nice amount of bone gain, and that allowed us to go forward and to perform the surgical re-entry. And this is the result that we got 2 years post-op with the X-ray and intraoral pictures. And now I think the case is in function, the implants are in function for at least 6 years. Going now to my last case, a bony defect of a complex case. Actually, this patient came in requesting an implant because he thought that something was fishy with his upper right lateral. But unfortunately, there were also other things going on. So taking a look inside, going intraorally, there was no type of restoration missing, but implants inside. Full metallic bridge, PFM crowns, composites, amalgam restoration, glass ionomer fillings, what you name it, everything was inside, and also good oral hygiene, which was very helpful, but many functional issues, a class 2 occlusion with a big overjet. And after seeing that x-ray, of course, the patient had to do a CBCT, and we saw how big the cystic defect actually was. And speaking with the patient, we decided firstly to treat and get some healing in that area, and then maybe to extract or leave one incisor or just to extract the lateral. The pus was coming, the liquids were going through the central incisor and the lateral, as you have seen. We treated the endodontically these teeth and placed an apical plug of MTA. And some 14 months later, when we did the CBCT, we got some bone remineralization, indicating that we were on the right path of treatment. So having that in mind, we went for the surgical procedure. We extracted the lateral only. We did raise the flap afterwards. We did the chemical cleaning. We did the thorough degranulation, or by using also the degranulation buzz. We did the retrograde filling of the central incisor, again with MTA. And because this defect was pretty scary, we used the rotated pedicle flap to close the defect. And here you have the suture. And what I like for you to see in these videos, part of videos of the surgery, the most important part, in my opinion, is that with the help of good biomaterial, I hope you can hear this also, the volume of this video, because once the material sets, it's hot, so you do not have any problem with the material going from left to right, or you do not have the hassle with placing the membrane. So it's a good way to close a defect. In this short videos, you see the rotated flap, also the steps of placing biomaterials, and then the final closure. So going again with the CBCT, after some time, half a year later, we see that the defect is almost closing, and the CBCT, of course, looks far more better than we started. We have in the upper left corner the two printed models of the defect before and after. And although I have the rushed printing the second model, you can see the improvement. Then first it was a two-wall the gap was huge, but we got a good result when in terms to the bone reconstruction and of course of the tissue healing. Going to my conclusion, why I chose this synthetic biomaterial, because you do not use a membrane, because it's biological, of course. It respects our biology, it's biocompatible, bacteriostatic, and it's also inductive. It's good, and I like biomaterials that transform into bone, as I have shown in the cited articles. And with having this in mind, you can achieve predictable results, in my opinion. As our father of dentistry said, I always think that we should have our eyes open and ears to any novelty, to any innovation that is available, but to carefully read also our literature to see exactly if that step is worthwhile taking. And I still consider myself a student. I will constantly be one, as Black said, and I'm trying to do things as to the best of my abilities. But as Einstein said, a person who never made a mistake never tried anything new. So we should try also new things, but always be careful on every step that we take. I thank you for your kind attention, and I invite you to see our journal still, and be in contact with us. And also, I would like you to invite to access this Master of Implantology at the University of Jaume Valencia in Spain, for anyone who might be interested of learning something new and different. Thank you so much, everyone, for your attention.